My name is Raquel Redtfeldt. I practice pediatric and adult ENT in the East Valley. My training is general ENT. Then I did a Otology fellowship and then an Allergy fellowship. Today I'm going to talk mainly just about acute otitis media. In your handout, there's a very lengthy talk that would have taken me about an hour and a half. I was a bit too ambitious, so I've cut it down to just the acute otitis media slides. Please do, especially if you are treating mainly adults or are in sort of a adult and pediatric practice, to look at the other slides, because acute otitis media is really going to be about the under 5-year-old patient. So acute otitis media and other headaches. I'm sorry, earaches. Full disclosure, neither I nor any member of the planning committee have any actual or potential conflict of interest in relation to this presentation. So we'll review the anatomy of the external ear and the middle ear. We'll talk about the diagnosis and treatment of acute otitis media. I'm going to say over and over again that this is a disease of children under 5 years of age, and that we'll talk about why that is. We'll define otitis media, review the clinical practice guidelines, and then that the adult earaches and otitis externa and that will all be in your slides, but we won't talk about them. So on your slide, you should be able to see the normal eardrum with the computer's right or on your left. You can see that it's beautiful. There's no redness, no swelling. You can see through that drum essentially. That's a normal eardrum and the portions of the ear canal that you can see on exam. And then on the right, there is a bulging drum. It's erythematous. You can't see through that drum. It's very thickened, and that looks like a painful ear, and it is. So the definition of acute otitis media, again, a disease of children under 5 years of age, is that it's the first 3 weeks of a process in which there's acute onset of inflammation. So they go from being normal to sick pretty quick. It's an infection of the middle ear with signs and symptoms of that. So there's bulging of the eardrum, redness, the child's in pain, they have a fever, and the most common time to have this happen is under 5 years of age. The peak incidence is at a year, and most of the time this starts off with a viral upper respiratory infection. I stuck in the otitis prone definition in there, which is 3 or more events in 6 months, or 4 or more in a year. So once you've gotten a recurrent situation where acute otitis media is happening over and over again, then you're otitis prone. So on the anatomy, we're really looking at the eardrum primarily, which can be hard to do in an under 5-year-old. So you have this tiny little ear canal and a screaming kid, and they're squirming all over the place, but you really do need to try to get an exam. You don't have to see the entire eardrum. If you just saw a tiny section of that eardrum on the right, you'd see that there was bulging and redness. You don't have to see the whole thing to get an idea of what's happening in there. So look above and around the wax that's in there and see if you can get a good exam. It's really impossible to make the diagnosis of an acute otitis media without some visualization of the drum. So this is sort of the why it's in under 5-year-olds instead of adults. And in this slide, you can see that the eustachian tube, and I would say it's even shorter than it is pictured on here for the infant. So very short, very flat. It allows bacteria and viruses to get from the posterior nasopharynx into the middle ear space. It can just travel right up that eustachian tube. So the length and the angulation is poor for the infant. That changes as we grow up, and really by the time we're about 5 years of age, our eustachian tube is angulated, it's lengthened. When they go from that little baby face to a little boy or little girl face, that process has happened. Additionally, our immune system's different as we get older, and then this adenoid. So these are pictures of the nasopharynx, and you can see that the adenoid in the image to the left is big. In a sick kid, that's going to be red, inflamed, and very, very gooey. There'll be mucopurulence all over that. And then on the right, where you see the arrows, That's an adult nasopharynx, and the arrows are where the eustachian tube is. You can't even see that on that infant one, and that's because that adenoid is so big. And so there's a bunch of mucopus in that little cleft between the adenoid and the eustachian tube or the torus tuberous, and it's just a setup for an infection. So for acute otitis media, what we're looking for as clinical criteria would be an abrupt onset of severe ear pain, 24, 48 hours of that, a high fever, 102.2 or higher, a moderate to severe bulging eardrum, intense redness, and we really want to see those things. If you don't have one of those, think about delaying treatment, because really you should have all of those if the child really has an acute otitis media. In a really good summary paper, this is Alan Liebenthal et al., and they show these images of what they are describing as normal, which is A, mildly bulging, B, moderate and severe bulging, C and D. And we really do want there to be, most of the people you diagnose with this should really have moderate to severe bulging of the tympanic membrane. The problem is that B, that mild bulging, if that kid is pretty sick, high fever, ear pain, and they're under 2, you're probably going to treat that ear too. But moderate to severe bulging is the clinical criteria. So what's the treatment? They are in pain. They do have high fevers. We're going to treat that first. So it's going to be ibuprofen, acetaminophen, whether you're alternating that or giving those in combination or using one or the other, whatever works is fine. And then topical benzocaine. Those are over the counter now. So Otic is a form of topical benzocaine. Oralgan are also over the counter. Those two have antipyrine in them also, so they have a topical NSAID plus the benzocaine. I think they are helpful, if not for the child, for the parent to feel like they're doing something for pain to the ear in specific. And then if the child that presents with that nasty eardrum that we just looked at and the fever and pain is under 2 years of age, then you are going to treat them. You're not going to wait and observe. You're going to treat them with high-dose amoxicillin, 90 mg per kg divided BID, so that's 45 mg per kg per dose, and it's going to be a 10-day treatment. You're going to see that child again in 48 to 72 hours. I'll explain why you're going to see that kid in 48 to 72 hours, but you're going to reassess them, and if they're better, meaning fever's better, pain is better, that ear might not look a lot better, because again, this is a 3-week problem. It's not going to immediately respond to high-dose amoxicillin, but the child should be less sick, and if they are, then you can just finish off that 10 days of high-dose amoxicillin. If they're not better, they still have a high fever, mom's still having to alternate doses of ibuprofen and acetaminophen, and the kid is still a mess, then you're going to switch to Augmentin. And then if they're 2 years and older, when you first see them, you can have a discussion about antibiotics on the pediatric GI tract and the maladies that can come from messing up someone's microbiome, and try not to do an antibiotic. Especially if you have an immunized child, your chances of really having the problem go very south is very low because of the fact that we vaccinated and we have this lower strep pneumo infection rate for acute otitis media. And then for that 2 years or older child, if you did give them the high-dose amoxicillin, then they're going to be on the same treatment as the under 2-year-olds. If you didn't, then you're seeing them 48 to 72 hours later. If they're better, then you're just going to continue to do nothing, just pain relief and the topical pain. And then if they aren't better, you did the high-dose amoxicillin, then you're going to go to the Augmentin. In the 2 to 5-year-old, you can do a 7-day course. In the rare over 5-year-old that really does have an acute otitis media, you may go down to a 5-day course. Okay, so you can truncate that antibiotic course for the older child. There are some special situations where you would just go straight to Augmentin, and that is in the child who has otitis and conjunctivitis. So yes, that could be viral, but if it's been ongoing and you're thinking it's bacterial, then you're going to just go straight to the augmentin, because that's going to be more likely to be Moraxilla catarrhalis. And MCAT is often resistant to, 90% sort of resistant to Amox. So when do you have a new episode? So lots of these little kids, because of this Eustachian tube problem, because of the adenoid, because of the fact that they're immunologically not very competent, they can have bouts of this like every 2 weeks, every 3 weeks. When is it a new episode? And the answer is 30 days. So if that child comes to see you, you do your reassessment in 48 to 72 hours, you finish that treatment even, but they come back 2 weeks after the time that you saw them, that is considered the same episode. You're going to just escalate from where you were. So if you landed on amoxicillin at the end of the last time you saw them, then you're going to augmentin when you see them again. If you landed on augmentin, then you're going to proceed to ceftriaxone, and we'll talk about that escalation here in a coming slide. If they're over, 30 days are over, then it's a new episode, and you go right back to just pain management and amoxicillin or waiting. So here's a couple more images of some ugly eardrums. They really should be ugly. If you're talking yourself into an Otitis Media, you're probably talking yourself into an erroneous diagnosis. The eardrum really should look very bad. Why do we start off with either observation or high-dose amoxicillin? There's some spontaneous cure data that that depending on the bacteria that's infecting the ear, you could have as high as an 80% spontaneous resolution. So if you have M. catarrhalis infection, you could give them nothing and they have an 80% chance of resolving it on their own. With H. fluids, 50%, and with pneumococcus, it's going to be 20%. So there's this spontaneous cure. There's an overdiagnosis. Again, we've got this screaming kid, a tiny ear canal, and we may not get a good look, and we have a distressed first mom, and so they may get overdiagnosed and overtreated. So we would rather start with a high-dose amoxicillin than augmentin for the adverse drug effects that you'll see with augmentin. Again, for the microbiome, the clavulinate is really rough on the kids' GI tracts. So the pediatric infectious disease doctors agreed with the Pediatric Academy to start with high-dose amoxicillin or observation. There are some special situations. Here's again 3 more pictures of ugly eardrums. They really should look like that. The one to the far right has a little teeny perforation there. In a primary care office where you don't have a microscope and ability to suction a drum out, you're not really going to see that hole usually. There's just going to be pus all filling up the ear canal. But when you do suction all that out, you'll see these little holes from ruptures. Okay, so that's why one of the criteria can be otorrhea. So for the neonates, we really need to be a little bit more worried about them. If they're under 2 weeks of age and they present with an acute otitis media, that calls for a full sepsis workup. That infection isn't usually going to be the 3 organisms that we expect. Instead, it's going to be birth canal sort of bacteria, group B strep, gram-negative enteric bacteria, chlamydia, and in a underdeveloped, immunologically underdeveloped person, that can be a very serious problem. So they're full sepsis workup. They should be sent to the pediatric hospital. If they're over 2 weeks, then they just fall back into that under 2-year-old category, and you can treat them with high-dose amoxicillin. So if you're allergic to amoxicillin, you're going to go to the cefdinir, the cefuroxime, and again, I'll go there. My next slide's going to kind of give all those antibiotics and their dosages, and then I have a pet peeve. I really don't like clindamycin, so it's on there, but I do think it's really rough. So this is it isn't quite from this paper, but it is very close to the recommendations from the paper listed there. The only difference is that I put the azithromycin on there. That paper strongly advises against azithromycin. I think that You often will get a penicillin cephalosporin allergic child, and there are limited options, and azithromycin is a reasonable thing to use for your first line treatment in a penicillin allergic child. So you're going to start off with the amoxicillin. Then if they present with otitis conjunctivitis, you're doing Augmentin. If they're under 2, you're doing 10-day courses. If they're 2 to 5, 7-day. If they're over 5, 5-day. If they fail on that, you're going to jump over to where it says after failure first line treatment is going to be Augmentin, and then potentially Rocephin shots. If they're penicillin allergic, then you're going to go from that third generation oral cephalosporin to a Rocephin shot, the ceftriaxone shots, which is going to be a 3-day course for them. And this paper recommends that 3-day course of ceftriaxone be combined with clindamycin. And I think you're completely safe to do ceftriaxone for the 3 days, see if it works, and then only escalate to ceftriaxone and clinda if you really have continued high fever and pain. And I think if you're in that after failure penicillin allergic zone where you're treating with ceftriaxone, you really should be consulting ENT, even potentially if you're not at the 4 in a year mark. So who is otitis prone? Really, any under 5-year-old could become otitis prone, but the risk factors are being male, white male, family history of recurrent acute otitis media or tubes in the family, daycare exposure. Those ones that are underlying the family history and the daycare are the strongest predictors. And then if you get unlucky enough to have your first acute otitis media under 6 months, you're probably going to have a problem. You are very likely to become otitis prone. Contributors, so those were not necessarily high risk factors. These were basically things that would make you have a few more ear infections. So if you're allergic, you could have a few more infections. If you use a pacifier or do this bottle propping thing where they literally can construct an apparatus to have the baby feed with this device, if you feed your baby supine, smoking parents, lots of other kids bringing infections home from school, etc., those are contributors. And then the only mitigator that we have is breastfeeding. And then, of course, not having these other things, not sending your child to daycare if you possibly can, and then breastfeeding for the first 6 months of life. And then there's the graph of really who gets acute otitis media. Again, it's a disease of under 5 years of age patients, and you can see on that graph that includes that basically just goes out to 3 years, and you could make the argument that this is a problem for under 3 years and under. The clinical practice guidelines from the Academy of Pediatrics and the ENT Academy, they agreed that otitis prone is the 3 and 6 months, 3 or more in 6 months, 4 in a year, that those children should be at least seen by ENT, that ear tubes are an option, and the language is very gentle on recommending ear tubes. And part of that is that we've got this big overdiagnosis thing. And so there is this, it's an option. And then on our end of it, on the ENT's end of it, we are not supposed to be putting ear tubes in if the child doesn't have findings, objective findings of a eustachian tube problem. So either a middle ear effusion on tympanometry or a negative pressure eardrum. And I will see those kids that have infection after infection and they have type A TIMPs when I see them. I do follow them for a bit, and the vast majority of them will ultimately meet criteria and go for an ear tube. On occasion, that kid's done with it, and you're just seeing them sort of at the tail end of it. So the ear tubes are tiny. They have 1 millimeter openings. They are inserted in the eardrum, so you make an incision, a myringotomy in the eardrum, so a hole in the eardrum, and then you put the tube through it and you put some drops in it. I had a patient complain to me once that they had to switch ENTs because they, put a hole in their eardrum. And of course, the person went for a myringotomy and tube placement, and that's what you do. It's a procedure. And it ventilates the ear. So you'll evacuate all that mucopurulent stuff that's in there, the serous effusions that are in there, and then you'll equalize pressure. And then that ear will be able to avoid an infection. It's not perfect, but it does work very well. Once the child has ear tubes, you can treat those infections just through the ear canal. You can put the drops, otologic drops through the ear canal to go through the ear tube and into the middle ear space, and avoid the oral antibiotics. And most often those kids are less sick. In fact, the parent will say, I didn't even know he was sick. He just woke up with this gunk coming out of his ear. Sometimes that secretion is so thick that you really do need to coach parents to get it cleaned out a bit. I do have patients use little blue bulb syringes and have them suction the gunk out. It is very mucoid, and so it can be hard for drops to penetrate it. For the young child, we don't do these water precautions. So see these little bit older girls with these ear bandits on, and those are for the older child. Usually the older child with an ear tube isn't having recurrent acute otitis media. They're having just eustachian tube dysfunction, hearing loss, a middle ear effusion with less infections. And so if you have an older kid, you might have to put an ear bandit on them and have them wear an earplug. But for the little ones, unless they're really swimming deeply, which most of them aren't, you don't need to do any water precautions. The pictures on the right there, that's a Reuter bobbin tube. I don't use those often unless I have someone who likes to spit tubes really quick. The tubes should last 6 months to 18 months. If they really spit them quick, I might switch the type of tube I place. And then the middle image there with the tube that you can't quite see the edges of it, that's a T-tube, and you'll look, you're looking down the barrel of that tube. It's a longer tube, it's a longer lasting tube. It's a little harder for them to push out. So we're going to go to our case presentation. So we have this cute little kid, and she's 20 months old. She is otherwise healthy, but mom brings her in because she's had a very high fever for over 24 hours. Mom's been dosing ibuprofen and acetaminophen, alternating because she will spike a temp just 2 or 3 hours after a full dose of ibuprofen. And she's got severe left-sided ear pain and thick colored stuff coming out of her nose for the last 24 hours. And prior to the last 24 hours, she had a kind of not so interesting runny, watery nose, and had a low-grade fever, and that went away after a day on ibuprofen, so mom didn't bring her in. And then this more serious infection sort of started. Her past history is that she's had 3 acute otitis media in the last 6 months. She started daycare 6 months ago, and that started this string of infections. And her last acute otitis media was both ears, and it was 3 weeks ago, and did respond to amoxicillin. So this is her exam. The top image is her right ear. That is the ear that was infected 3 weeks ago. So you can see there's still an effusion there, but that ear's not actively infected. It's not red, it's not bulging. And then there's her left ear, bulging, red, really looks painful. Her temperature, she was warm to the touch, and her temperature in the office is 101 on the ibuprofen and acetaminophen her mother's been giving her. She's got a little redness in her throat. Her lymph nodes are a little bit swollen. She's got a bit of a wet cough, and it's really hard to get a good auscultation of her lungs because she's crying. So that's a left acute otitis media that's now within 30 days of her prior acute otitis media. So she's in the same episode. So we landed on amoxicillin last time, so we're gonna proceed to Augmentin at the dosing of the 90 mg per kg. I usually just dose the amoxicillin portion. I've never had the clavulinate be off, but if you're really, into math, you can dose the clav part, but usually you can just dose the Augmentin by their weight and you'll be fine. And then she is otitis prone. She was actually otitis prone with her last infection. Her third one in 6 months would have made her otitis prone. She certainly is otitis prone now at the fourth one in 6 months, and she should be sent to ENT. At her ENT visit, we get that history that she's had 4 bouts in 6 months. 2 were bilateral, 2 were unilateral. That left ear has had a couple more than the right ear. She's responded to amoxicillin most of the time, but she has gone to Augmentin a couple times. And the next bullet there, that they're all associated with colored nasal drainage, but no persistent nasal obstruction or sleep disordered breathing. That's really a screener question for, does this child also need their adenoids removed? So for her, yeah, they all come with a gunky nose, but that nose completely clears up. She doesn't have snoring, and she breathes fine through her nose when she's not sick. She is in daycare 5 days a week. There's no smokers in the home, and then there is eustachian tube dysfunction, recurrent acute otitis media in her family, her siblings, and her father. That image on the right there, that is a representation of a tympanogram. So the top one is actually her left ear. That's the ear that was recently infected and bulging and gooey, and that eardrum's not moving. So that's a flat tympanogram. We call them a type B tymp. And then the left one is at a -278. That's a type C. So either one of these ears showing either one of these findings would meet our criteria for confirming that they really do have eustachian tube dysfunction, that they really do have recurrent acute otitis media, and that they should proceed with tubes. So that is it in a nutshell. We're talking about a middle ear infection in under 5-year-old patients. We are going to treat them primarily with pain management and antibiotics and a follow-up. And then once they get more than 3 and 6 months, more than 4 in a year, we're going to send them off to ENT, and then the ENT is going to do assessments of whether or not there's continued middle ear dysfunction and whether an ear tube would help them. And that's my talk.